the esteemed chairpersons and the organizing committee. Imaging precision for the prostate cancer. I would like to start with this case, a 69-year-old patient after prostatectomy and elevated PSA level with a negative MRI. The PSMA PET-CT demonstrated focal active lesions at the prostatectomy bed indicating recurrence. And in another case, a metastatic pelvic lymph nodes from the prostate cancer, left iliac lymph nodes, and in the same patient, we detected a pathologic lymph nodes in the axilla, which are not active on the PSMA, and those lymph nodes tend to be a leukemia. So we can differentiate between the PSMA metastatic lymph nodes from other malignancies. In this case, the MRI demonstrated lesions at both lobes of the liver. However, with the PSMA, only the left lobe lesions are active. So what's the PSMA? PSMA is a type 2 transmembrane protein, is overexpressed in prostate cancer, and is also expressed in normal tissue as a salivary glands and small bowel. So our talk today will be about the molecular imaging of prostate cancer. The function of PSMA in prostate cells is still unknown. However, studies showed an oncogenic signaling role for the PSMA in prostate cancer. There are different tracers used to image the prostate cancer, including the choline, the fluocyclovine, and the PSMA. In Egypt, we are using the PSMA in two forms, the fluorine-18 and the gallium-68. And these are images demonstrating the different tracers. In the blue box, the gallium-68 PSMA-11 is predominantly excreted by the kidney. And in the red box, the fluorine PSMA, fluorine-18 PSMA 1007, and it's excreted by the liver. There are different papers comparing the gallium-68 and fluorine-18 PSMA. And here is the comparison. With the fluorine-18, you are getting a more pure compound. The half-life for the fluorine is 109 minutes compared to 68 minutes for the gallium-68. Knowing that the PET crystal is adjusted at a 511 keV and the fluorine is at 633, so it's more matching with the PET crystal. The spatial resolution for the fluorine is a 1.4 millimeter. The image noise is lower for the fluorine. Now, the fluorine is a cyclotron, and it needs a lot of, it's a facility with expensive materials, and it needs a lot of money. The gallium is a generator, so it's cheaper. The fluorine being a cyclotron product, you are always getting a quality report for the fluorine. However, for the gallium, it is difficult to have the quality report for each production, and it's also deteriorating over time. As I said, the fluorine PSMA is excreted by the liver, so you're having a little amount of activity in the urine, and in this case, you can clearly see the active extension of the prostate cancer to the urinary bladder, and it will be difficult if you are using the gallium-68. So indications for the PSMA PET-CT in prostate cancer, the main indication currently is the biomedical recurrence. It's also used in staging with other new applications available. Most notable is the PSMA-guided theranostics per therapy. In the biomedical recurrence, so which tracers to be used? As we said, there are different tracers to image the prostate cancer, and most of the papers are demonstrating that the PSMA is more specific and sensitive than other tracers. In biomedical recurrence, the detection rate for the recurrence is high with the PSMA at a lower PSA level. And in this meta-analysis included more than 1,300 patients. The detection rate for the recurrence is increasing with increased level of the PSA. The sensitivity for the PSMA PET-CT in biomedical recurrence is about 90%, with specificity reaching the 99%. And in this patient, a 70-year-old male patient with a history of prostatectomy and now elevated PSA level, we can see the small active lymph nodes in the left external iliac by having the PSMA PET-CT. The PSMA PET-CT also will affect the clinical management, as in this paper. It's a prospective study, included 150 patients, and there has been a major modifications in the treatment strategy in more than 50% of patients. And in another meta-analysis indicating the change in the clinical management, the management has been changed in more than 50% of patients. In this pooled study included more than 1,100 patients. This is a case, a biopsy revealed the prostate cancer, and we can see the active bilateral external iliac lymph node, and also we are detecting a very small bone deposit in the left acetabulum. So the performance of PSMA PET-CT for the primary staging in the intraprostatic tumors, the pooled sensitivity is 70% and the specificity is 84%. In this patient, we can demonstrate the active lesions in both lobes of the liver. And regarding the lymph nodal staging, the pooled sensitivity for PSMA PET-CT is 61% with a specificity of 97%. Now, looking at the bone deposits, comparing the PSMA PET-CT to the skeletal, to the bone scan, the PSMA is more sensitive and specific in detecting bone deposits. And you can see here, this is the same patient. The bone scan is detecting few active lesions, metastatic lesions in this patient. And the same patient imaged with the PSMA PET-CT indicating widespread deposits, active deposits in the bone. Now, if you are talking about the new clinical indications, guiding the biopsy toward the most active lesions in the prostate, also it's helping the radiotherapy planning, with a change in the radiotherapy planning ranging from 20 to 60% in patients by using the PSMA PET-CT. And new clinical indications, including the monitor response to therapy, there is a good concordance between decrease in the SUV max and decrease in the PSA level better than CT. And new clinical indications, including the guided theranostics pair therapy using the lutetium-177 PSMA, and using the lutetium-177 PSMA, it improves the progression-free survival in 40 to 70% of patients with a metastatic castration-resistant prostate cancer. Now, how we do the interpretation for the PSMA PET-CT? We are using the PSMA reporting data system version 2. And first, we have to give a score for the level of the activity. The difference between the version 1 and version 2 is that the score 0 is given to any activity which is equal or below the blood pool. Now, the score 3, which is the high score, is when the activity is higher than the parotid gland activity. Now, for lesions outside the prostate, we are giving the PSMA RADS. It's ranging from 1 to 5. 1 is the benign lesions, 2 is likely to be benign. Now, the tricky one is the PSMA RADS 3. These are the equivocal lesions. There are 4 categories in this area, including AB. There is an equivocal activity in the lesion. A, when you are seeing a small lymph node on the CT or MRI, and there is an equivocal activity in it, and the recommendation is a follow-up. B, when you are seeing equivocal activity in the bone with no definite underlying CT change, recommendation is also the follow-up. Now C, when you are seeing the intense activity but it is unusual to be a metastatic site for the prostate cancer. It can be a non-prostatic malignancy. Recommendation is further imaging or biopsy. D, when you are seeing no activity, however, there is a malignant features on the conventional imaging, and the recommendation here is the biopsy. Now 4, when there is intense activity and is likely to be malignant. 5, and there is biopsy indicating a malignancy. And the 5T is a previously treated prostate cancer metastasis with or without uptake. Now, for lesions inside the prostate, we have in the peripheral zone and the transitional zone. Any activity in the peripheral zone is considered to be significant. Activity in the transitional zone needs to be twice the activity in the background to be significant. And this is a correlation between the molecular imaging TNM for the PSMA and the TNM 8th edition for the prostate cancer. I'm highlighting here the molecular imaging TR, which is a recurrence after radical prostatectomy. Also for the end stage, the regional lymph nodes considered to be the internal, external iliac lymph nodes, as well as the presacral and obturator lymph nodes. For the metastasis, the A is a non-regional lymph nodes, B is the bone deposits, whether it is a unifocal or oligometastatic, and C is other sites, metastatic sites from the prostate cancer. Now, regarding response to therapy, if you are using the PSMA, there are 2 ways to do that. There is a classical way, which is a disease progression, stable disease, disease regression, and complete response. However, the more practical way is the PSMA PET progression. It is only 2 categories, which is progressive disease, and it is considered when there is increased more than 30% of the volume of the lesion, or when you are having 2 or more lesions, newly developed lesions active on the PSMA, or only 1 active lesion in the presence of consistent lab and clinical data. So everything else will be a non-progressive disease. So these are new tools that already available in Egypt, and we are using it. The artificial intelligence highlighting the tumor scout, and with this tool you can highlight all the sites of the disease, and you can calculate the tumor burden. We are using it for response to therapy. Also, we can label the primary site of the disease, and in this case, the artificial intelligence label the small involvement of the right seminal vesicle. Also, for all our patients, we are doing the PET-CT MRI fusion. We're doing a complementary limited sequences of MRI, the T2 and the diffusion, and we can fuse both images. As in this case, there is an active lesion on the left lobe of the prostate, and in this case, where both lobes of the prostate are involved with an active lesions. In this case, this is prostate cancer under therapy, and the case has been followed with the MRI diffusion. The diffusion is improved over time. However, the PET-CT PSMA demonstrated, and the active lesion is still noted in the left lobe. So with the PSMA PET-CT, you can detect a small sclerotic lesion, as in this case in the vertebra, and even a tiny lesion, as in this case. In conclusion, the PSMA imaging is sensitive and specific for patients with prostate cancer. It can detect the site of biomedical recurrence. It has a role in staging with a significant impact on management strategy, and it can be used for monitor response to therapy. I would like to conclude with this case. This is a patient who performed the PSMA and FDG. You can see that the small active lymph node, metastatic lymph node, the right common iliac lymph node, it is active on the PSMA and it is not active on the FDG. In the same patient, there is a lesion, sclerotic lesion in the right iliac bone. It is not active on the PSMA and is active on FDG. On the follow-up, it tends to be benign. And in the prostate, you can clearly see the active lesions inside the prostate, which with a mild activity on the FDG images. And thank you.